Chairman Wu, Ranking Member Smith, good morning and thank you for the opportunity to discuss health information technology standards. My name is Richard Gibson. I am a practicing family physician and former emergency physician and have nearly 20 years experience in health information technology. On the status of current standards, the Meaningful Use Final Rule has been well received by providers. We applaud the Office of the National Coordinator and the Centers for Medicare and Medicaid Services for seriously considering the many comments received over the past 9 months. They have been extraordinarily responsive in making rules as straightforward and as pragmatic as possible, while still moving the country forward to electronic health records that promise to improve the quality and consistency of health care. Concerning the standards-related priorities for the futures, my comments will go to the area of helping small practices in the short term to connect to each other directly, while we await the more complete and widespread health information exchange. We need a standard for transmitting provider text notes. Providers expect to be able to review the text reports produced by other providers. Historically, these text reports have been produced by transcribing notes that physicians dictated, say, for an office visit, a consultation note, a surgical procedure, and the like. We need a specific continuity of care document or continuity of care record for these tech documents to be most useful for patient care. We need a standard for exporting and importing patient information directly between EHRs and directly provider to provider. Meaningful Use Stage 1 does not require EHRs to have the ability to export and import patient information directly to and from other EHRs. As clinicians move to electronic health records, we need to enable our EHRs to transfer patient information as easily as fax machines accomplish that transfer now. The office staff needs to be able to press a button to send information to the next physician. This concept and the next two have been promulgated by Wes Rischel of Gartner and have led to the NHIN Direct project. We need a standard directory for health internet addresses. After a provider decides to refer the patient to another physician, the provider or her staff member could go onto the internet and search for the provider's authenticated health internet address. This could be entered into the sending physician's electronic health record, which would send an encrypted packet of information directly to the receiving physician's electronic health record. Later, states will need a record locator service so that emergency departments can pull data from the patient's previous providers. We need a standard for document transfer that can accommodate providers still on paper records. It will be years before all providers have electronic health records. We need a standard that sends patient information like an email attachment so that providers on paper records can still print the information. Once they do get an EHR, the same attachment could be imported into that EHR. We need an EHR functionality requirement for quality measure reporting. Smaller practices under the current rules would likely need to seek the help of consultants to produce an acceptable quality measures report. This reporting needs to be core EHR function specified by a consistent nationwide requirement so that providers in any practice can again press a button to produce submission-ready reports on a chosen measure. We need a national model for privacy and patient consent. In Portland, we often see patients from Southwest Washington. Having significantly different privacy laws between Washington and Oregon would lead to uncertainty, misinformation, and the unnecessary duplication of diagnostic testing. We need a federal effort to convene, sponsor, and mandate development of model rules and laws that each state could take through its own legislative process. We need to set appropriate expectations on provider access controls to patient information. In our largely fee-for-service healthcare system, one cannot exactly predict which doctor or nurse will take care of them on any given occasion. Our model needs to set the expectation in the patient's mind that it is not possible to predict precisely who will need access to their record in the course of their care. Finally, we need a model for the complete health record being available to the provider. Although the provider can infer some of the patient's diagnoses from the medication list and allergy list alone, it is crucial that providers see all the medications and allergies when they prescribe. Without this guarantee, patients could be hurt. Similarly, providers need access to the full laboratory and imaging reports when they're trying to make a diagnosis. Redacting these data because they imply a certain restricted diagnosis is unsafe and could ultimately result in physical harm to the patient. Chairman Rue, Ranking Member Smith, thank you for the opportunity to testify on these important issues. I would be happy to answer any questions you may have.